I'll let you know when the final talking poster's here, just so that you know.
Thanks.
Okay, good evening. Welcome to the ASGBI Centenary Free Papers session. This is another in one of the many sessions that the ASGBI have put on over the summer months, using technology to hopefully bring to you some of the work that's been going on around the country. This free centenary session this evening is from the Emergency General Surgery Free Papers series, with papers looking at NELA data, emergency general surgery and cancer data. I'm Sonia Lockwood, I'm a consultant surgeon from Bradford. I'm also the surgical lead for the NELA project. I'm one of your moderators. And with me this evening is Brian Dobbins, who's a consultant of the GI surgeon from Huddersfield and is the regional rep for Yorkshire and Humber for the ASGBI. So we're going to go straight on into the first of the short papers, and that's Jiwan Zhen, who's looking at clinical implications of epithelial protein lost in neoplasia in colorectal cancer. Mr. Zhen.
Okay, so good evening, everyone. Thank you for the opportunity for me to represent my team to share our findings between colorectal cancer and a molecular we focus on called EPLIN. Next slide, please. So, as you all know, colorectal cancer was the fourth most common cancer type and the second most cause of cancer death in the UK, attributed to these factors presented in these slides. While taken together, it needs our wide understanding of development of colorectal cancer and novel markers for therapeutic strategies. Next slide, please. So the molecular focus on called epithelial protein loss in neoplasm, so-called EPLIN, NEMA1 actin binding protein 1. So it's a actin cross-linking protein that has been reported to be downregulated in a range of cancers when compared to their normal peers. So in cellular studies, EPLIN plays a key role in regulating actin dynamic and multiple key processes in development of cancers, such as EMT with other interrupting proteins. Besides, different level of EPLIN could affect cell functions. In clinical aspect, lower level of EPLIN is related to poor clinical outcome and development in breast cancer and prostate cancer. Therefore, it has been labeled as a tumor suppressor. Next slide, please. So this leads to a really simple question. Does EPLIN play a same role in colorectal cancer like it does in other cancer type? So based on our findings, the answer is positive. Here we access the transcript expression of EPLIN in two independent clinical cohorts. From the left-hand side, you can see is from China. The right-hand side is from Cardiff. So the highlight of our finding is that EPLIN transcript expression is significantly diminished in tumor samples when compared to normal ones in both cohorts. But unfortunately, little significant difference was noted in regards to other pathological information. So in conclusion, EPLIN is downregulated in colorectal cancer tissues when compared to normal tissues. and this potentially implicates that EPLIN may play a key role in development of colorectal cancer, but deeper study needed to confirm our findings. Thank you.
Thank you. So as part of the introduction, I forgot to mention there is a Q&A section at the bottom of your screen. If you've got a question for any of the panelists or presenters, please put a question on there. So I'll kick off the proceedings. You talked about the clinical implication of EPLIN.
Yep.
Do you foresee a practical or application to it? Could it be used as a screening tool or equivalent to try and identify patients at risk of colorectal cancer?
Well, it's a really good question, thank you. But for now, mainly the current studies is focused on research aspects. So no, not in the clinical, practical influence, but in the future, we hope that will become one of them. Thank you.
Okay. Any other questions from the floor? Okay. Thank you, Dr. Jen.
Thank you.
So we'll move on to the second paper. Jennifer Pollard is presenting our August guidelines on MRCP for acute biliary disease adequate for use in a district general hospital.
Thank you for the introduction. So my name is Jennifer Pollard. I'm an ST6 in general surgery in Rigmore Hospital in Inverness. I'd like to present an audit on the use of the AUGIS guidelines for MRCP in acute biliary disease in a district general hospital. Next slide, please. Gallstone-related pathology accounts for up to a third of all emergency general surgery admissions and referrals, and waiting for an MRCP can prolong inpatient stay. In 2015, the Association of Upper GI Surgeons produced guidelines on the management of gallstone-related disease. They acknowledge there's a number of problems in managing acute gallstones in the emergency setting, including a lack of access to rapid ultrasound scanning, restricted access to emergency theatre lists because LAC-COLI is not deemed an emergency, lack of access to urgent lists, and variable skills in intraoperative cholangiogram and CBD exploration. They developed a pathway to encourage safer and more cost-effective management of acute gallstone disease and describe stratification and standardisation of treatment options and concise management plans for the majority of cases in any hospital. The AUGIS guidelines recommend only using MRCP when there is both biliary dilatation and deranged LFTs, specifically an elevated bilirubin. And this audit aimed to establish whether their implementation would be appropriate at our institution. Next slide, please. So all emergency general surgical admissions in Rigmore Hospital who underwent an MRCP between the 1st of January and 31st of December 2018 were included. There were a total of 182 patients who had an MRCP within that timeframe, and 111 were eligible for inclusion in our audit. Patients were then stratified into one of 4 diagnoses as per the AUGIS guidelines, and we collected data on why they were having an MRCP, their ultrasound finding, and their LFTs. And statistical analysis was performed using a chi-squared test. Next slide, please. Of the 111 emergency admissions who underwent an MRCP during the study period, 48 patients were confirmed to have choledochal lithiasis on MRCP, which equates to 43%. This table shows the predictive value of bilirubin versus ultrasound findings in our cohorts, with all of the results being statistically significant. Elevated bilirubin was predictive in 53% of patients, whilst dilated CBD on ultrasound with a normal bilirubin was predictive in a third. The presence of both elevated bilirubin and dilated ducts on ultrasound predicted CBD stones in 65% of patients. However, strict adherence to the AUGIS recommendation that only these patients should have an MRCP would have missed 33 patients with choledochal lithiasis, which equates to 29.7% of the total, or 68.8% of those with ductal stones. Next slide, please. The ability to preoperatively diagnose choledochal lithiasis is important in services where there's a mix of subspecialists undertaking on call, such as in a district general hospital. Undertaking MRCP only in the presence of dilated ducts and elevated bilirubin would have missed almost 70% of patients with ductal stones in our cohort. Our institution has a liberal approach to MRCP because it's easily available, but this translates to a high positive yield based on our clinical acumen, with 43% of patients having an MRCP positive for CBD stones. Furthermore, within our patient group, raised bilirubin alone seems to be a satisfactory indication for MRCP, correctly predicting CBD stones in 53%. Thank you.
So the first question from the floor is your trust part of the Sunflower randomized control trial? They used bilirubin of up to 50 to randomise to no MRCP. Do you think this is an appropriate cutoff? And that's from Marianne Holliman.
So as far as I know, I don't think we are part of that randomised trial. I'd need to check with our consultant. And sorry, what was the cut-off that you mentioned there?
50 or above.
50. So for ours, we actually just used a bilirubin of greater than 21, and we showed that 53% of the patients would have a stone on CBD. So I think there would be some scope for negotiating what your cut-off would be, but certainly in our trust, a greater than 21 would be considered abnormal.
Yeah. So we're in the Sunflower study as well where we work, so that was going to be my question. The second is that many smaller hospitals, in fact many bigger hospitals, don't have a liberal approach to MRCP because they don't have ready access to it. So I suppose that cut off again, did you look at your data and work out where the yield would be that would indicate MRCP or straight to surgery?
So we didn't specifically look at the cutoff for the bilirubin with that, no. But I agree, you're right. I think the fact that we've got easy access to MRCP, probably easier than access to ultrasound sometimes, actually makes it easier to do this in our trust, and difficulties accessing MRCP are known. So I can understand why ultrasound is a step. I think our thought process behind it was if you have a pathway of liver function test, ultrasound scan, MRCP, and then a definitive management plan, is there a way of cutting out one of the steps to make it both cost effective and time effective for the patient? But I guess that's very much dependent on what services are available in your hospital. Okay,
and then one last quick question. What time do you get MRCP, and do you have to wait for a period of time? Is an early scan picking up stones that may have passed, is the question again from Marianne Holliman.
Yeah, so I think that's a reasonable thought. We're looking at within 48 hours getting an MRCP from when it's requested in our trust. So it may well be that these stones could pass on their own without us needing to do any intervention.
Lovely, thank you very much. So next speaker is John Canny. He's going to talk about the treatment of emergency large bowel obstruction with colonic stents as a bridge to theatre, a dual centre experience. Johnny.
Good evening to everyone. Thanks very much for the opportunity to present. As you said, we're going to discuss our two large Northern Ireland trusts experience of colonic stents as a bridge to theatre. Next slide, please. So we all know that malignant large bowel obstruction is common. Up to 1 in 5 patients who present with, 1 in 5 patients with left-sided colonic malignancies present with mechanical obstruction, and 1 in 4 patients who die following colorectal surgery originally presented with obstruction. Emergency surgery is risky, and stents have long been used with palliative intent for large bowel obstruction, but recently have been used more commonly as a bridge to theatre. Next slide, please. Electronic notes research and radiology records between the two trusts, looking at over a 10-year period at patients with presenting with large bowel obstruction in the emergency setting. The other inclusion criteria was that a curative resection had to be planned following stenting, and if the stent was for palliative purposes only, then this excluded the patient from the study. Next slide, please. So 48 patients were originally considered for stent as a bridge to 30 for surgery, and of those 39 had successful relief of their obstruction by stenting. 2 subsequently blocked within the 48 hours following that and proceeded to emergency surgery, along with nine others, given 11 patients who underwent emergency surgery. 34 patients eventually progressed to elective resection. Median time to surgery was 22 days, and the mean age was just less than 70. 2 of the emergency surgery patients died, and none of the stent patients died in 30 days following the stent or following the elective procedures following that. Next slide, please. As you can see, the majority of the resections were done as open open procedures with smaller amounts laparoscopically, but that changed as time went on in more recent years. Next slide, please. And there was a lower rate of stomas in more recent years than there had been previously. Next slide, please. This shows a pie chart. Sorry, it's not really come out very well. Showing the reasons for stent failure. The majority of the reasons where the endoscopist was unable to get the stent across. 2 patients, as I said, blocked within 48 hours, and 2 perforated, 1 at the site of the obstruction and 1 at the cecum. Next slide, please. So we believe this is a credible, safe alternative to emergency surgery, although it's not for every patient. There's significantly lower mortality. It allows time for optimization of comorbidities and complete staging, transfer to colorectal surgeon, and possibility of laparoscopic surgery with no stoma. However, there is a risk of perforation, converting a tumor to a T4 tumor, not suitable in unstable patients or where there's obvious compromise of bowel, and specialist staff, radiologists and radiographers are as required, and it delays the definitive procedure. Thank you very much. Any questions?
Yeah, thank you. I will ask as a non-colorectal surgeon rather than Sonia grill you, but a couple of things. Bearing in mind, obstruction often presents with pain. Would you be advocating waiting for a stent? And secondly, it is quite a technically difficult procedure to do. And bearing in mind, I think I've worked out that only 27% of the working week is in 9 to 5 periods during Monday to Friday. Would you be advocating an on-call for such stents?
Well, the practice and the trust that I've presented the data from would be only to stent between 9 to 5, but also on Saturday and Sundays and daylight hours. I think with patients present with large bowel obstruction, most of us CT scan the patients, a combination of clinical acumen, CT scan, and inflammatory markers can decide then who needs surgery at night time and who can wait until the following morning for a stent.
So if you had a tender cecum, would you?
No, I would. Well, our practice would be if there was a tender cecum to go straight to emergency surgery.
So I think Brian's question should hopefully answer that. That's come through the chat from Marianne Holliman about whether there was an inability to stent due to lack of available staff, presumably either out of hours on weekends. So the second question has come from Ilana Jolliman, who said, how many patients with colonic perforation after their stent insertion did you encounter? So I suppose the question is stent complications. Do you have perforation or migration in your cohort?
Yeah, as it was a bridge surgery and the time frame was quite short, then there weren't any migrations of stent. There were 2 patients who perforated, 1 at the site of the obstruction, 1 cecally. There were no other perforations in the time following surgery, in the time following stenting. But obviously, with more numbers, there would be more, probably more perforations.
Okay, so just one final question, which is I suppose quite topical. We've used stenting quite a bit more during the COVID period as a semi-elective bridge rather than an acute setting to surgery. Is that something you've experienced locally with you?
No, it's not something that we've used personally, more because of COVID. Our practice hasn't hugely changed in Northern Ireland, as we've been relatively spared.
Okay, thank you very much. So our next speaker is Daniel Lang de Silva, who's going to talk about emergency laparotomy in the elderly population, assessment of perioperative risk and long-term outcomes after surgery.
Thank you very much. Good evening, everyone. So my name's Daniel. I'm an SHO in Worcester, and I'll be presenting a study we conducted which looked at the use of perioperative risk scores in predicting poor long-term outcomes amongst patients over the age of 70 undergoing emergency laparotomy. So there's emerging evidence that markers of frailty are potential predictors of outcome in patients undergoing general surgery, as proposed by the ELF study last year. Most recent NELA report suggested that despite a higher overall mortality, only 23% of patients over 70 were reviewed by a geriatrician compared to 92% of patients with an ecofemur fracture. So the objective of our study was to determine if conventional parameters such as P-POSSUM are predictive of short and long-term outcomes in this patient population. So we performed a retrospective review of all patients over the age of 70 who underwent emergency laparotomy in Worcestershire Royal Hospital between January 2017 and January 2018. Next slide, please. We divided our sample of 151 patients into 3 groups according to their P-POSSUM score, which is there on the left. Fortunately, it's changed a bit. There was no significant difference between the groups in terms of age, sex, Charlson Comorbidity Index, and residence at admission. As expected, those predicted to have a higher risk of mortality had a higher ASA grade. However, this was not the case for frailty. Patients with different levels of frailty were found in all 3 groups. When we compared the groups, those with a higher risk of mortality had significantly longer admissions, higher mortality in hospital, as well as at 90 days and at 12 months. They were more likely to be admitted to ITU, and they were more likely to require residential care 12 months post-surgery. Interestingly, despite the different predicted risks of mortality, there were no differences in incidence of medical complications amongst the 3 groups. Next slide, please. Looking at survival and P-POSSUM, patients in the high-risk group were less likely to survive, as shown by the Kaplan-Meier on the left. We also saw that the Charlson Frailty Index and the Rockwood Frailty Score, which is on the right, they were similarly able to discriminate between patients who had good or poor outcome post-surgery. Next slide, please. So in conclusion, our study has shown that a higher preoperative P-POSSUM is associated with poorer short and long-term outcomes. The Charlson Comorbidity Index and the Rockwood Frailty Score were also predictive of poorer overall survival. Patients in the high-risk group did not develop more medical complications than the other groups. However, they stayed in hospital for longer, which may lead to a loss of independence and increase in care demands both in hospital and on discharge. And these issues need to be addressed by the use of a more holistic approach when caring for these patients. Thank you very much.
Thank you. I don't dispute many of what you've said. So what do you think about the P-POSSUM in relation to the NELA risk score? Have you looked at any data that may tell you the difference between the 2?
Sorry, the P-POSSUM and? The
NELA risk score for patients undergoing emergency laparotomy.
Mm-hmm. I'm afraid I haven't looked at data looking at the 2.
So P-POSSUM overpredicts for very high risk groups, and therefore it's difficult. So second question is that the best practice tariff came into effect that says that patients who have a risk more than 5% should automatically get admitted to critical care. Do you think that would make a difference in your cohort?
I think definitely yes. It would make a difference in the cohort. I'm not sure in what way it would affect the other results that we found in which the P-POSSUM positively predicted risk of them occurring. But yes, it would.
Brian?
Yeah, just saying, I mean, some of the data that you have, it still shows us a lot of people with high risk still survive for 5 years, more than 50%, regardless of the risk. And with the frailty scores, it's perhaps only the 5, 6, and 7 frailty, and particularly 7, that whereby you would have to argue that is surgery the right thing to do. So bear that in mind. Do you use this sort of data in your institution to use it in terms of consent for patients to make an informed decision as to whether or not surgery they would undergo surgery?
So my experience is from the colorectal department in which it is used in that decision-making process. I can't say for the different departments, but definitely in the colorectal one.
Okay, thank you very much.
Thank you.
So we'll move on. Apologies if I don't get the name correctly, but it's Manuk Venturante, talking about using snippets to improve efficiency in writing emergency surgical discharge summaries.
Thank you very much. Hi all, my name is Manik Rajaratna. I'm a general surgical registrar in the southwest of England. I'm presenting today about using snippets to improve efficiency in writing emergency surgical discharge summaries. Next slide, please. Emergency surgical discharge summaries, or TTOs, are essential for patients and clinicians alike, providing vital information for both primary and secondary care. Providing high quality, clear TTOs in a timely manner is challenging due to several factors, largely systemic issues, including lack of familiarity with the level of detail and information required, and simply the volume of work that an on-call brings. Some hospitals have made it mandatory for patients to have their TTO prior to leaving hospital, and this has implications for patient flow through hospitals, with knock-on impacts on coding, patient and staff well-being, and most importantly, patient safety. For example, the follow-up not being arranged in a timely manner due to the TTO not being issued. Therefore, the aim of this project was to improve efficiency of issuing TTOs in the emergency setting. Next slide, please. So this very straightforward QI project was done in November 2019. The system in the hospital that I worked in was that all outstanding TTOs from the week on call were done in a specified room by the junior finishing their on-call week. The time to complete these accumulated TTOs was measured discretely at the end of 2 consecutive on-call weeks in order to determine a representation of workload. On the back of this, pre-formatted text known as snippets were then produced using the established electronic patient record system. An example of this you can see in the top right of the screen. And this allowed you to populate sections of the TTO by a single click rather than having to type, and included a range of discharge diagnoses, clinical narratives, and follow-up plans. Information on the snippets was shared with junior doctors, and the time taken to complete TTOs following the introduction of snippets was measured discretely, and a follow-up survey was also sent to junior doctors to assess usability. Next slide, please. The results were very encouraging. So the average time to complete a TTO pre and post introduction of snippets fell by almost 3 minutes. Before snippets, average time to complete a TTO was about 7.6 minutes, n equals 37 TTOs, and after snippets, 4.7 minutes, n equals 31 minutes per TTO. Extrapolation of these findings suggests time savings of over 8 hours per week for junior doctors in a trust receiving 25 referrals in 24 hours. All surveyed junior doctors agreed that snippets made writing TTOs faster and helped them understand the ideal detail required. So in conclusion, having pre-formatted, easy to populate TTO text can significantly reduce time required to complete emergency surgical TTOs. It's yet another string to the bow of improving efficiency, with significant knock-on effects on streamlining services, improving patient safety, and improving well-being at work. And further work will be to introduce snippets to elective TTOs with standardized specialty information. Thank you very much.
Thank you. I have more concerns when it comes to the quality of a discharge summary rather than the speed at which my juniors can write them. Has your study assessed whether these snippets are perhaps snippets of information rather than the actual full lot of information that is often, I believe, is more important than the time it takes?
Sure. So I suppose what we were finding is that a lot of discharge summaries were over the top, so they had too much information, if you like, and actually this particular cohort of people that had TTOs were short stay patients, so they only stayed for maximum a week, and they were looked after essentially by the same clinician, usually the F1 or the core trainee or the registrar doing the discharge summary from that week. So really it helped people write discharge summaries for patients that they already knew they weren't doing discharge summaries for patients that they had no idea about and were just populating using the snippets. It was clearly a useful adjunct to writing the TTO as opposed to used all the time.
I think Mr. Dobbins beat me to it. That was my exact question. The accuracy of information is probably better than the speed to complete it. Have you thought about doing some work to get feedback either from GPs or indeed the patients as to what they think of the quality of these TTOs and whether actually they are fit for purpose if they're so limited in the detail that's included on them?
Sure. I definitely thought about it, yet to do it. So I think generally what we found was that most of the information given to patients on the discharge summary, for example, pertaining to wound care post-op or driving information post-op. And there are several audits that I've come across in the past which are specifically looking at these points of information. They have almost always been included since the snippets have been introduced, and that would be a separate audit to look at in future. I think in the system that we use, the information for GP comes up right at the top of the discharge summary for the GP, and usually this is much more what we've found, that with the snippets they've become much more clear cut as to what we want the GP from the GP really.
I ask you one last, how long is your list of snippets that you have to trail through before you get the...
So actually it's quite a clever system. So for each different specialty, we've managed to create, so for upper GI surgery, for general surgery emergencies, upper GI or colorectal, urology, vascular, you can choose a section of snippets and then you can populate them from there.
Okay.
Thank you very much. And then the final paper for this session of short papers is from Stella Smith, and she's going to talk to us about apples and pears, the effect of inner city population demographics on national emergency laparotomy data. Stella.
Hi, thank you very much. My name is Stella Smith. I'm a general emergency surgeon working at Manchester Royal Infirmary, and I'm presenting this on behalf of the EGS group in that hospital. I'm going to talk today about the effect of an inner city population demographic on national emergency laparotomy audit data. Next slide, please. Manchester is one of the fastest growing cities in the world. It has a high rate of socioeconomic inequality, life expectancy up to 8 years younger in deprived areas, 1 in 4 children live below the poverty line. The catchment population of Manchester Royal Infirmary covers inner city areas where inequalities are reflected in high emergency laparotomy crude mortality rates. This study compares the MRI patient demographic to the UK population. Next slide, please. Comparative summary demographic data from patients undergoing emergency laparotomy in 2019 were obtained from the online NELA reporting tool, together with denominator data from publicly available NELA data entry reports. Patient descriptors such as age, ASA grade, operative urgency, indication, and the procedure performed were compared. Next slide, please. Nationally, 23,000 patients underwent an emergency laparotomy in 2019 in England and Wales. There are 128 patients at Manchester Royal Infirmary in the same time period. Next slide, please. MRI patients were on average 20 years younger than the UK population. Next slide, please. They had a higher ASA grade. Next slide, please. The operative urgency was more severe, with a high proportion requiring surgery within 6 hours. Next slide, please. The most common indications for emergency laparotomy at Manchester Royal Infirmary was perforation, 40% of patients versus 28% of patients, with more patients presenting with peritonitis, 34% of patients versus 24% of patients, and intra-abdominal abscess, 12% versus 6% of patients. There was, however, no statistical difference in the clinical indication for surgery. Next slide, please. There was no difference in the procedures performed, except for stoma revision. The crude mortality rate in Manchester Royal Infirmary is well over 10%, but adjusted mortality comes down to 5%. Next slide, please. There are significant baseline differences between inner city patients in Manchester compared to the general population that contributes to a higher reported crude emergency laparotomy rate. Adjusting for these factors, more than halves our reported mortality rate to well below the national average of 9.6%. Thank you.
Thank you.
Thanks,
Go ahead,
Philip.
then, Mr. Dobbins.
I'll go and I'll ask first. First of all, I think part of your results could be because your hospital's not built, looking at the last slide. But secondly,
it's not my hospital.
secondly, I see your laparotomy rates for the year were 128. Now, I suspect Manchester Royal Infirmary has a bigger catchment area than Huddersfield Royal Infirmary, and ours is 200 plus. Is your data collecting everything in order to draw these conclusions?
Yeah, that's everything on our NELA report.
It's not necessarily every laparotomy then.
Well, it won't be any of the laparotomies that are not present in the NELA data sets. No. So your trauma laparotomies, for instance, which we do quite a lot each year, are not present in that.
But we know from the NELA data set that only 85% hospitals reach 85% case ascertainment, and below that, you would get triggered for being below. So comparative with HERS, I think what Mr. Dobbins is saying is how sure are you that your case ascertainment is at 100%?
It's not quite 100%, but it's well over the 95% mark. So we do pretty well on that. We've got dedicated NELA nurses and data administrators. So we do pretty well. The reason why we've only got small numbers is because we've got a high number of hospitals in the inner city Manchester area. So you've got Salford next door, you've got Wythenshawe just south, and then you've got a variety of other sort of local emergency hospitals in the locality. So actually there's a big concentration of hospitals within a small geographic area within Greater Manchester.
Okay. So nationally, the most common procedure or indication for laparotomy is a small bowel obstruction. The most common procedure performed is a degenylysis. You report perforations. Were you able to try and tease out what organ is perforating and why you might have a higher perforation rate than elsewhere in the country?
I haven't delved into the data in that much detail to really answer that question. We do a significantly smaller number, or none of it's statistically significant, but it looks to be a smaller number of right hemicolectomies, of sort of segmental resections, subtotal colectomies, that sort of thing. So we're sort of doing quite a lot of small bowel work. We're doing quite a lot of upper GI perforations, but no, I can't give you anything with any more definitively.
Yeah, so Tom Poulton, who's a previous NELA fellow, has published his PhD last year, which shows that social deprivation is a key risk factor for people undergoing emergency laparotomy. There's an independent risk factor, actually. How do you think you can go about improving outcomes for those who live in a socially deprived area?
See, I don't think it's about medicine. I think it's about all of the social factors that go with living in a deprived area. So it's about nutrition, it's about smoking, it's about high levels of drug and alcohol abuse, and all these things that we've got within the inner city population within Manchester. And it's about trying to improve public health as opposed to really anything that we could do on a sort of hospital front, I think. But obviously, again, I'm making an awful lot of assumptions there without any specific data to relate to that.
Thank you very much.
Thanks.
Okay, that concludes the short paper session. We're going to go swiftly on to the talking posters. Mr. Dobbins is going to moderate.
So again, we'll keep strictly to time. And I think I reviewed 3. How many are there? We've got 5 people turned up. Okay, let's get things going, and we'll start off with pregnancy testing in women of childbearing age in the acute surgical take.
Hi, good evening. My name is Nikita. I'm one of the SHOs in Royal Derby Hospital. This poster is made of an audit that I did in my Foundation Year 1 training, titled Pregnancy Tests in Acute Surgical Patients. The idea for this audit emerged when there was a Datex incident in the department when a patient was taken down for theatre for laparoscopic appendicectomy. However, she hadn't had any documented pregnancy tests done. This understandably led to delays in not only her care, but subsequently also other patients who were on the emergency surgery list. So on discussion with the consultant on call, it was decided that perhaps it was worth looking into what went wrong and if there's anything we can improve. So the objectives were to identify all women of childbearing age, which was defined using Royal College guidelines of 16 to 55, and to see how many of these had a pregnancy test done and how many were accurately documented. The target was at 100%. The data was gathered from multiple sources, such as the Clarking booklet, as seen there, blood tests as the beta HCG level, or nursing documentation in case of none of the above two being available. For the purposes of this audit, if there was no documentation in any of the above, it was assumed that the test was not performed. The first round noted that only 56% of the patients who were eligible had a pregnancy test performed, of which only 28% were accurately documented. The key points highlighted were the inconsistency in the sources of results, as mentioned above. There were multiple places, verbal handovers between departments without the documented results coming up, for example, from ED onto the surgical nurses. Based off of these points, the second audit cycle was performed with recommendations in place, such as posters in SLUICE and a doctor's office to remind them for effective documentation, reinforcing good record-keeping behaviours on the quarterly junior doctor rotation, and discussion with the nurse in charge of surgery and the nurses on the ward to ensure that when verbal handovers are done by emergency department, to only accept when the paper copy of the pregnancy test comes along with it, and to reject it otherwise, and to repeat the test. The results in the second round significantly improved, and 80% of the patients had a pregnancy test performed, of which 61% were documented clearly. Despite the positive results seen in the second cycle, the target was still not met, and there was still significant room for improvement. The conclusion in the audit meeting was to further and reach the target of 100%, it was potentially useful to have a changeover of documentation to one source only, perhaps an electronic version in one of the clinical applications that we use in the hospital, to ensure there was consistency and for it to not get missed out. Thank you.
Thank you very much. Just a quick couple of questions. Number one is, how many positive tests in your studies?
So from the first round in the 50, we only had about 3 positive tests. And from the second re-audit out of the 55, we had no positive tests.
And my second question is, are you implying that every patient, if you're female in that age group, regardless of what they're presenting with, should have a pregnancy test?
Yes. Unless they've got valid documentation to say they've had a hysterectomy or sterilization. That was in the theatre checklist performer, that a valid pregnancy test was available.
Can I ask a quick question? So in your first round, 56% of patients didn't have their pregnancy test performed. Did that lead to a delay in any treatment? So how did they get any x-rays done if they've not got a pregnancy test result available? Our x-ray department won't scan anyone.
So the one shortcoming that we noticed was that they did have all the scans done, but we couldn't find any of the documentations. So the way the Kingsmill Hospital did documentation for pregnancy tests was on A4 slips of paper, which were there, but often went missing. So at the start of the admission, perhaps on the first day they were present, but often went missing, and that led to a cascade of events and redoing tests on multiple occasions.
Okay. Thank you very much.
Can we move on to the next? Effect of preoperative CT scan on negative appendicectomy rate, a retrospective study.
Hello, hi, I'm Safiya Ahmed, and I'm working as a transcript doctor in Scunthorpe General Hospital. We conducted a study, basically we looked into a study where we were evaluating about the preoperative CT scans and how the rates of negative appendicectomy rates are. The thing is that we came to know because a few of the consultants, they were wanted scans before negative, even if they were clinically positive and equivocal for appendicitis. So we wanted to look how the negative appendicectomy rates occurs on patients who have have scans or doesn't have scan. Traditionally, it was usually, we used to go for appendicitis even if there was an equivocal clinical diagnosis. But given the fact that nowadays there are broader availability and frequent scans, so to diagnose the appendicitis, that's a gold standard test for appendicitis. Our aim was to see how the scans affect on the negative appendicitis rate and whether they have impact on age or gender, and whether there are any association or not. So we went through retrospective analysis and took the patients from January 2018 till April 2019 who underwent appendectomy. And the histological diagnosis were labeled as microscopic inflammation of transmural inflammation. We excluded those patients who underwent a diagnostic lab, and so that to minimize the bias. We identify 187 patients in which the mean age was around 34 years. So out of these, 35 patients were identified who was less than 16 years of age, and males were around 95 out of 187. The patients who had preoperative CT scan was 114, that is around 60% of our patients, in which there was around 6% were the patients who had a CT scan. And 33 did not have any scans on children age, and while in adults there were around 112 who had CT scan. And so we found out that overall the negative appendectomy rates were 11%, and it was most significantly higher in those patients who did not have a CT scan. And interestingly, what we found out that the 6% was those who had a CT scan but were still, their histopathology report came back as negative appendicitis. That was something interesting that we came to know. Regarding seeing into things that in females, we found that 40% of the patients who were negative appendicitis, while in males it was lower to 8%, while in male and in children and in adults there were 11% of negative appendicitis rate. So in conclusion, we found that negative appendicitis rate is higher in those patients who don't have a preoperative CT scan. So we wanted to see that why it's underutilized in preoperative scans and to find out the scan results. And what we found out is that the patients who were reproductive age, especially in females, we were a bit hesitant to make them to undergo radiation, and so those are the persons who were more to have negative appendicitis rate.
Thank you very much. We have a question from Marion Holman. In the 6% of the negative appendectomies in the CT group, was the CT equivocal, and if it was, did you have the reports re-reported or looked at again?
They were not equivocal. They were two of them were equivocal, but the other were they reported it as acute inflamed appendicitis. But no, we didn't go for histopathology to re-report the histopathology reports.
So, as an old man, do you think we're getting lazy at being clinicians by ordering all these tests? What's your opinion?
Well, to look into it, what I have found out that nowadays we are more relying on scans rather than on clinical judgment, and as with the days and technology coming up, we are getting more used to relying on the scans rather than clinically judging up. Even if we feel like yes, this is an appendicitis, but still we go for our go for the radiological diagnosis. And the second thing that I had a discussion with my consultant saying that why do we not rely on our clinical judgment, and they were like, we need a positive result to prove to the patient as well as ourselves that that you have appendicitis and need to go for surgery.
Yeah. You mentioned there was a significant higher rate of negative appendectomy rate for females, but you then said you excluded diagnostic laparoscopy for
Yes,
females.
but those
Seems
were
a bit
the
of a
patients.
dichotomy of opinion there as to.
Yes, so we excluded the diagnostic laparoscopy, but the females who were clinically who did not have a CT scan and were clinically we were suspicion of appendicitis, but they came back as the age group between them between the reproductive age were higher. I don't know, those patients who went into diagnostic lab, we excluded them just to minimize that, but the patients who were reproductive age and who were clinically with suspicion of appendicitis, they were more common.
So there's just one more question from Ilana Joyman, which is, do you use a special scanning protocol for children? I'm just going to add to that question that you have a 20% CT rate for under 16-year-olds. That seems very high. We'd struggle to get almost 20% of our patients under 16 CT. So
20%.
So you said 18.6% of patients were less than 16. So nearly one in 5 children are getting scanned.
It was 2 of the children who had a scan. 6%, not 60.
All right. So I'm just reading your abstract. But do you have a special scanning protocol for children? Is the question for you?
No, it's just the same that we go through everyone. Yeah.
Okay.
Well, thank you very much. And we'll move on to our next poster presentation, diagnostic accuracy of ultrasound in pediatric population with acute right iliac fossa pain.
Hi, good evening. My name is Rabia, I'm one of the SHOs at Tameside General Hospital. So I'll be talking about a study that we did looking at the diagnostic accuracy of ultrasound in children with right iliac fossa pain and suspected appendicitis. So we know that appendicitis is the most common acute surgical emergency amongst the children. And ultrasound is the first line investigation that we use. However, it still remains a diagnostic challenge. So our aim for this study was to determine the sensitivity and specificity of using ultrasound for diagnosing appendicitis in children with acute right iliac fossa pain. So it's a retrospective study that we did looking at 100 consecutive cases of children presenting to the ED with acute right iliac fossa pain. All the children that we included in our study had been seen by a member of the on-call surgical team, went on to having an ultrasound scan. So we went back through the electronic medical records and recorded the radiological findings, the outcomes, so whether they were operated on or managed conservatively, and then the pathological findings, so the histological findings, outcome after that, so discharged or kept in hospital, any post-op complications, and any readmission with similar presentation of acute right iliac fossa pain. So just talking about some numbers, we had 23 confirmed cases of appendicitis, 17 of which were preoperatively diagnosed on the ultrasound scan. 13 of these were female and 10 were male patients. We found that the next most common finding was mesenteric adenitis amongst children. Ovarian cyst was common amongst female patients. We also had a single finding of UTI, hernia, Crohn's disease, and a rare finding of neuroendocrine tumour, but that was referred to a tertiary centre, so we lost the information on that because they were managed at a tertiary centre. So we found that our specificity was 92%, so in comparison to our sensitivity, which was 74%. Our radiologists were better at picking up negative cases and saying that it was negative for appendicitis. Even though our sensitivity meets the Royal College of Radiologists guideline, they say that it should be greater than 70%. We would still have to consider how we improve our diagnostic accuracy and how we improve diagnosing appendicitis to avoid negative appendectomies. So there was only 3 appendectomies which were performed with a normal histology. However, you would want to avoid that in the future. We obviously appreciate our limitations as a DGH with our ultrasound. We only have 2 ultrasound radiologists that do pediatric scanning. There's not a list every single day for pediatric patients to be scanned. So we need to take those things into consideration. but we can say that our negative rate was better than our positive rate, so we're better at excluding appendicitis, and ultrasound is a useful imaging modality. However, we need to discuss and consider whether there's any scope for using MR scanning or CT scanning. However, being a DGH, a small DGH, whether this is feasible in the future, I'm not too sure. It would have to be discussed more, but I think that's it. Thank you.
Thank you very much. Just looking at your sensitivities and specificities, this is only calculated on those that you took to theatre, though, isn't it? It's not. There's a lot of people that you will scan that never actually see go to theatre, which would affect how good a scan is, because you'll get a lot of. So would you do an ultrasound scan on everybody who comes in with right iliac fossa pain as a kid?
Yeah, I think at the moment, this is pre-COVID, we were scanning almost every paediatric patient with right iliac fossa pain. So a lot of them were reported as normal, which went on to being normal. So 66 of the 100 were normal on ultrasound. They didn't go on to have anything else, any further input. So I think, yeah, you're right. So these are the numbers from the patients that were taken to theatres.
So there is a question from the floor. Who did the ultrasound, consultant or sonographer? That's come from Anonymous.
Yeah.
They were consultants. So all the reports came from both consultants. Yeah.
Sorry, Ms. Burton, I was just going to follow up on that question. We know that it's user dependent is ultrasound. So when one of those two members of staff is not present in the hospital, what's the service that you give to the children then?
So at the moment, what we do is if we have a clinical concern that is appendicitis and the consultant on call feels like it is appendicitis based on their clinical judgment and examination, they would proceed to doing a diagnostic lab anyway. But we have, at the moment, what we do is we send the patient home and then to come back the next day when the ultrasound radiologist is back to have an ultrasound the next morning. Admittedly, it's not the best service. It causes a few problems. Patients get confused. Their parents aren't too happy with them going home and coming back to hospital. But I think it's just the capacity of the hospital and how we have to deal with things.
Based on that, a child comes in with a raised white count, rebound tenderness, and Rosling's positive. Would you send them away and get an ultrasound scan?
No, I think we would probably proceed to take that patient to theatres and do a diagnostic lab.
Excellent. So this clinical examination still wins out in the end.
Yeah, definitely. I think it goes hand in hand, but clinical examination takes the top tier on that one.
Good. Excellent. Well, thank you very much.
Thank you very much.
So next paper, a comparison of post-operative antibiotics and no post-operative antibiotics in patients undergoing emergency open appendicectomy for acute non-perforated appendicitis, a meta-analysis of randomized control trials. Have we got somebody who's presenting this?
So we should have Igor Malioko.
He's online, but we can't hear him. Igor, can you hear us? We can't hear you.
So Igor, I don't know if you want to log off and log back on and just allow all permissions for your audio and video. And we'll move on to the next paper just while we try that. Is that okay?
Yeah.
Next paper is audit of consultant review times of emergency general surgical patients. Are we meeting NHS standards?
Hi, my name is Neil Christian. I'm a core surgical trainee in the West Midlands, and today I'll be presenting the audit my team conducted on consultant review times for emergency general surgical patients. So, why is this audit important? Senior decision making is a key factor in the quality of surgical patient care, and early consultant review is vital, not only for the recognition of acutely ill patients, but also associated with less diagnostic error and reduced length of stay. NHS England produced a set of 7-day clinical standards that were designed to ensure that patients admitted as an emergency receive consistently high quality of care, regardless of the day that they enter the hospital. We therefore decided to audit our our unit's adherence to two of these standards. The first was that consultant review time must be within 14 hours of admission, and in addition, that high-risk patients with predicted mortality greater than 10% should have consultant involvement within an hour. The second is that all ITU patients should be reviewed twice daily by a consultant. So moving on to the methods, this is a prospective audit of all general surgical admissions from ED or GP referrals over a 28-day period in November. A performer was designed to collect the data, as you can see below, which included time of admission, time of consultant review, and PPOSM or NELA score where appropriate. So moving on to our results, we analysed 133 emergency admissions, and the median time to consultant review was 12 hours 45. Looking at the pie chart on the right, only 55% of patients received consultant review within 14 hours. In addition, ITU patients were reviewed twice daily by a consultant only on 67% of days, and of the 3 patients with greater than 10% risk of mortality, only 1 was discussed with the consultant within an hour. So based on the initial results, our department were unable to meet NHS standards for consultant review time. As a result, we have made changes to the on-call consultant structure and introduced a daily 5 PM consultant ward round of new admissions. As you can see from the second pie chart, the introduction of this ward round would have led to 91% of patients in our audit being reviewed within 14 hours, and the median time to review would have been reduced to only 7 hours and 30 minutes. So based on this data, the value of our change appears to be significant, but a re-audit will be performed in 3 months to confirm this. It's also important to note that the value of early consultant review is dependent on the availability of diagnostic and support services, such as prompt access to imaging out of hours. Thank you for your time, and I'd welcome any questions.
This is a study which I certainly can relate to with the way that we changed our rota in Huddersfield. It's not surprising, really, is it, if you only do a ward round in the morning and then wait till the following day for your next proper ward round, that your times are going to be extended. Can I bring up one point in particular? You say the availability of appropriate diagnostics is important. Does a consultant require every single test to be back in order to make a decision on these patients? Because that's what you're implying is, because when you go to see a patient, you shouldn't say, oh, there is, a hand on the belly, a look at the patient, regardless of whether they've had the CT. It shouldn't delay the time in which the consultant makes a decision. Is that right?
Sure. So I'd agree with you that clinical examination is, first and foremost our most effective tool of investigation. But a number of times I've seen on post-take ward rounds in the morning, a patient will have been resuscitated overnight or kept near my mouth, and the consultant will come and make the call for a CT scan. And in some cases, I've noticed that if that CT scan had been requested the previous evening, then perhaps that patient could have been expedited to theatre, or perhaps we could have put the request in for a radiological drain, and that patient could have been managed the next day. Whereas instead, sometimes these patients' managements are delayed, and then length of stay and outcomes may be compromised.
Can I also ask a question? You might not know the answer. Were your consultant colleagues happy to do an extra bit of work at 5 o'clock in the afternoon?
As you can imagine, they're extremely supportive of this, and welcome the audit and the results.
I've got a question. Of your patients, 33% was seen and discharged. Was that seen by a junior and discharged, or seen by the consultant and discharged?
That would have been seen by at least a registrar, or discussed with the registrar, but not all of them would have been seen by a consultant.
And do we know how many patients who are discharged after a junior review are readmitted? And what I mean by that is, the government guidelines say that 14 hours of admission. Do you think that the consultant needs to be involved in the patients that are being sent home?
What does happen is that all patients in our trust that are sent home are included on the take list. So every patient is discussed, if not with the consultant that evening, the next morning in handover. And there have been times where a consultant might have a different idea or like to arrange alternative follow-up, and then that is instituted the following morning. But obviously with the addition of a 5 PM ward round, that gives way to having that communication earlier and then changing the plan or investigations as the consultant sees fit.
So I suppose the question is the patient safe for being in the hospital but not reviewed by a consultant or discharged by a junior home and out of the building?
I think with the registrar's input, they have appropriate experience to safely discharge patients where the clinical examination, they're not guarding a peritonitic, perhaps their blood tests and observations are stable. I think we can safely say that we can trust the registrar with that much experience to safely discharge.
Excellent.
Okay, thank you.
Thank you very much. Have we fixed the audio problem? Yes, maybe.
Igor, are you present to give your presentation, please? Just make sure you're off mute.
Can you hear me now?
We can hear you. Excellent.
Oh,
Thank
yes. Sorry about the problems. So my name is Igor.
I can't see you. Do you want to click your video as well? There you go. Excellent.
Better. Sorry about it. So my name is Igor. I'm one of the SHOs at the James Cook Hospital. So our team has did a meta-analysis on the topic of the appendicitis and comparing post-operative antibiotics and in addition to the preoperative antibiotics. So I want to talk a little bit about the background first. We know that acute appendicitis is the most frequent surgical emergency. And in terms of the non-perforated appendicitis, appendectomy is the gold standard treatment for it. In terms of surgical site infections, we know that that's the most common complication post-operatively. And we know that perioperative antibiotics reduce the rates of surgical site infections. That's been shown in the evidence. However, in terms of post-operative antibiotics, there is not much evidence to show any benefits for it. And despite of that, post-operative antibiotics are still routinely used in some centers. So that takes us to the reason why we did this meta-analysis, to establish the need for post-operative antibiotics in addition to preoperative doses for patients undergoing open appendectomy for non-perforated appendicitis. So what did we actually do? We've identified 4 randomized controlled trials at Medline, PubMed, and a few other online libraries. So you can see at your bottom left a summary of the trials and the 2 groups that we had in each trial, one having post-operative antibiotics in addition to the preoperative ones, and one group having no post-operative antibiotics at all. Our primary outcomes were incidence of surgical site infections and the length of hospital stay. So if you look at the top right, the results, there's a forest plot that shows us that actually there is no difference, there's no significant difference in the incidence of surgical wound infections between the patients receiving post-operative antibiotics in addition to preoperative antibiotics and the patients receiving preoperative antibiotics only. So our cutoff p-value was 0.05, and you can see here that the p-value is 0.91. And also you can see the numbers for the both groups. And looking at the second outcome, so length of hospital stay, we can see in our meta-analysis that patients receiving post-operative antibiotics, they actually stayed in the hospital marginally longer than those who received preoperative antibiotics only. Of course, that could be related to the fact that they just stayed in to complete their treatment rather than anything else. So that takes us to the conclusion of our meta-analysis that there is no value of using post-operative antibiotics in addition to the preoperative ones. And as I've said in the results, there is no difference in terms of the surgical wound infections between the 2 groups, and patients receiving post-operative antibiotics actually stay in hospital a bit longer. There's a few limitations to this study. First of all, we have excluded pediatric cohorts, and we've also excluded laparoscopic approach to managing appendicitis. We've also realized that our heterogeneity value for incidence of surgical wound infections is quite high. Therefore, the results for that must be taken carefully. And looking at both all the trials included in this meta-analysis, we know that there is some bias associated with all the trials. So thank you very much for listening, and I'm happy to take all the questions if there are any at all.
Thank you very much. So I've got a question for you. What is the indication for an open appendectomy in a non-perforated appendicitis?
What is the indication for open appendectomy?
Open appendectomy. So I'm not sure why you do an open appendectomy in this cohort of patients.
So we did this meta-analysis during the kind of COVID times, when there was a guidance, well, sort of recommendations from the Royal College of Surgeons England that there are risks associated with the aerosolization with laparoscopic appendectomy, and most of the appendectomies in our hospital were done openly, so we've decided to look at that.
Has this, when you presented this to your consultant colleagues, have they changed their practice? This sounds like something I've been doing for a while anyway. Is this?
Absolutely. Well, in our hospital, we don't tend to give post-operative antibiotics, but when I was thinking about this meta-analysis and when I researched the literature, there were a few studies that actually show that post-operative antibiotics for some reason are still used despite the minimal benefits.
Is there any data on adverse outcomes or complications from prolonged antibiotics?
Say it again, sorry.
So you've talked about length of stay and the incidence of surgical wound infections, but is there any data in your meta-analysis that looks at adverse outcomes? So for those patients that actually received a prolonged course of antibiotics, did they come to any harm?
No. So the other outcomes we looked at were things like intra-abdominal collections, need for further surgery, and any deaths. And none of these studies that were included in this meta-analysis have reported any of that at all.
Okay. Thank you very much.
Thank you, and sorry again about the...
Oh, no, we've got you now. Your technology's finally worked. So that concludes this evening's free paper session. I'd like to direct you to the website that you can see on screen at the minute. That's part of the ASGBI, and you'll be able to see some of the e-posters that have been submitted also in this category. I just want to ask if there are any of the attendees or panelists that have any questions that they'd like to raise based on the presentations that they've seen this evening. No? In which case, it just leaves me to say thank you very much to the panelists. Thank you very much to those that have contributed. To let you know that there is another session taking place tomorrow evening. You're more than welcome to attend. And we hope to see you in future ASGBI events.
Thank you very much. Thanks, Sonia.